Treatment. The radical treatment of carcinoma of the prostate is still indeterminate. Young is enthusiastic over total prostatectomy for the radical cure of those whose disease has not progressed beyond the limits of the gland. It is, of course, absolutely impossible to guarantee the patient against a metastasis, even at this time. Pasteau is almost equally enthusiastic about radium. A small experience with both procedures leaves us in doubt. Young's operation is very likely to result in incontinence of urine, though I have one case who made a good recovery and after a second operation to close a perineal fistula has complete control of his urine. I have seen brilliant mitigation of prostatic carcinoma by radium. In view of the gravity and danger of operation, the radium treatment is far preferable if it is employed with sufficient discretion to avoid burns. The palliative treatment, as in all cases of carcinoma, consists primarily in avoiding operative interference as long as possible. If there is retention, the catheter must be employed, though the encroachment of the growth upon the urethra often makes catheterism difficult. In case the catheter fails, suprapubic drainage supplies relief of a sort, though the pelvic pains continue and the patient is likely to go rapidly downhill. On the other hand, there is a great array of palliative operations whose success cannot, unfortunately, be predicated beforehand. Of every one of these operations, it may probably be said with justice that a very large proportion of them actually do no good to the patient. They may afford a temporary relief of symptoms, and this relief is likely to continue for several months, but no longer. Exceptionally, the functional improvement lasts for several years. The few cases in which various palliative operations are alleged to have cured carcinoma of the prostate, we may well refuse to pass judgment upon. Each method of prostatectomy is praised as being especially adapted to produce extraordinary results with carcinoma. Each form of prostatectomy has, in turn, received this special praise: intraurethral and extraurethral, perineal and suprapubic. Bugbee has reported very satisfactory results from cauterization of the bladder neck with the D'Arsonval current. He has thus succeeded in reducing the amount of residual urine very considerably, and thereby increasing the patient's comfort. I have not as yet been able to duplicate his results. While it is to be frankly admitted that radical cure is impossible as soon as the carcinoma has exceeded the limits of the prostate, and improbable in any case, palliative operations are so much more likely to do harm than good, and so unlikely to do anything more than temporary good, that even in so desperate a condition as carcinoma of the prostate, it seems unwise to interfere unless the patient's discomfort is very great. If, however, the catheter totally fails to control the urinary difficulties, one may fairly waver between the confessed failure of the suprapubic drain or the attempt to give temporary relief by prostatectomy. On the whole, I favor the drain.